Dr. Devi Shetty, welcome to this morning. My name is Navadan Kataria, and I'm very thankful to you to have spent your time. I know that you have to save a lot of lives at the hospital, but there are a lot of people who will get motivated and inspired from you and save lives after they hear you. So who needs introduction to Devi Shetty? I don't think anybody in the country or globally. So I'll leave that part of introduction absent in Dr. Devi Shetty's presentation, and over to you, Dr. Devi Shetty. Devi Shetty, please go ahead.
Thanks. Can I start?
Please go ahead.
Thank you. Good morning. First of all, I have 10 minutes, and in 10 minutes, I just want to talk to you first about the status of digitization in healthcare and how AI will impact. First thing, the world is buzzing with AI and its impact on the healthcare. I just want to let you know that AI is a fairly distant dream for healthcare as of now, mainly because 80% of the hospitals across the world, including some of the first world countries, do not use electronic medical records. Some of them may be having. That doesn't mean they are using it. So without having the data of patients' data on a digital format, no AI tool will be able to extract the data. So this is the grassroots reality that unless large-scale digitization of the healthcare happens, AI will not be a reality. That is the first thing. Now, why digital penetration hasn't happened? Mainly because the so-called American advanced electronic medical records literally cost over $1 billion, and we can't afford. And we unfortunately haven't produced alternatives in India. There are few attempts, and some of them are proving to be extremely smart. Now, in the next few minutes, I'll explain what we have done using AI before the ChatGPT and all this, the buzzwords started. We started using AI or a machine learning or all these advanced tools. We started using it nearly about 6 years ago, mainly to calculate the risk score of the patients. We run heart hospitals across the country. Today, about 14 to 16, 17% of the heart surgery done in India is done by our group. So we have a large presence in the area of cardiac care. So it's very important that we use these advanced tools to prevent sudden cardiac arrest happening in the hospital. Now, our first project was to eliminate cardiac arrest happening in a heart hospital in the ward. We are not talking about reducing the cardiac arrest. We are talking about eliminating the cardiac arrest completely. Why this is important? Because in a heart hospital or any other hospital, you will see that the nurses come in the morning for a shift. They take one BP apparatus. They go to the first patient, check the blood pressure, temperature, respiratory rate, saturation, and they write it down. It takes about 10 minutes to 15 minutes. Then they go to the next bed and the next bed and the next bed. By the time they finish recording the vital parameters of 30 patients, it's time for her to do it again. It is the most boring, mundane job for a smart nurse. They get bored. Worst thing is, when they go to a patient's bedside at 2 o'clock at night and start checking the blood pressure and the pulse rate, first thing what the patient does is to scream at the nurses because she has woken them up from his sleep and he will not be able to get back to sleep. A patient always screams whenever they are woken up. In the process, nurses, they are not left with any other choice other than lying. the record of the blood pressure, temperature, everything done at night. Generally in India, US, Europe, everywhere, it is not the real blood pressure. So in the process, maximum number of cardiac arrest happens in a heart hospital between 4 o'clock in the morning till 7 o'clock in the morning. Because at the night time, patient is not adequately monitored. Now, what is the solution? We tied up with a local startup called Cardiac Design Lab. They designed a patch which continuously gives the ECG with analytics. It gives the blood pressure, temperature, respiratory rate, oxygen saturation, and the restlessness of the patient. With these data, our analytics team calculated the risk score. And we are now in the process of launching it across the group hospitals. Our aim is to tell the nurses that you don't waste your time going to the bedside and checking all the vitals. You stay in the nursing counter, and nurses station will have a TV with all the 30 patients' name with 3 color flags, green, orange, and red. The risk score will monitor all the vital parameters. When the risk score goes up, say from 5% to 15%, the color of the flag changes from green to orange. Then the nurse will go to see what is going on with the patient. And that is a job she likes to do. And before the cardiac arrest happens, 6 hours to 12 hours before the so-called sudden cardiac arrest, patient generally gets restless, their pulse rate starts going up, blood pressure starts going down, temperature starts going down. So many changes happen. These subtle changes, human eye, especially at night, cannot decipher. Whereas a machine will continuously monitor and give the accurate risk score. Based on the risk score, the nurses can decide with the doctors to continue the care there or shift the patient to the ICU. So we hope to eliminate sudden cardiac arrest with this concept. The next area we are concentrating is the critical care unit. The building where I'm sitting here, we do about 40 to 45 heart surgeries every day, not cath lab procedure, heart surgeries. We have over 300 bed ICU in this building. Now, it is a huge task in getting experienced intensivists to manage these patients. Across the world, there is a shortage of intensivists. A patient in the intensive care in India or in US or Europe gets the best care between 9 a.m. to 5 p.m. when all the senior doctors are available. For 16 hours at night, evening, early morning, 16 hours, patient in India or in US gets suboptimal care, managed by junior doctors, junior nurses, and junior team. Now, first, how do you make intensive care job interesting? To make it interesting, you have to tell the intensivist that you do not need to do the night duty. Then who's going to take care of the patient? So what we are doing now, it's in the pilot stage still. We want to split the 16 hours when the patient gets suboptimal care into 4-hour slots and ask the intensivist to go home and monitor the patient from home. We have a very advanced digital platform which monitors, gives all the data. And using this platform, we will be able to know what exactly is happening. And more than that, our analytic tool, which calculates a risk score, uses 56 parameters which can change in the patient's body every second. And based on that, the risk score will keep going up and down. Say at 2 o'clock at night, a risk score has gone from, say, 5% to 20%. The intensivist at home has to just tap on that figure and the software will tell him what has changed in the last few hours for the risk score to go up. So a junior doctor who's present in the ICU can be instructed by the senior doctor that he has to carry out these instructions. So we believe that using these digital tools, which will warn the doctors about the possibility of a cardiac arrest at least 6 hours, 12 hours before, we can reduce the incidence of cardiac arrest in the ICU significantly. And this will be a game changer. These are the two activities we are actively involved. Hopefully, in the next couple of months, they should be operational across the group. Thank you so much for the opportunity. Most grateful.
Thank you, Dr. Devi Shetty. Thanks a lot for your all these views. We hope that next time you will be here in person so that people can engage with you on a deeper level. Once again, thank you for coming online. Once more.